So the next session, it's my great honor to co-chair with the next session, the Bioinformatics and the Cancer Genomics with Professor Ashley Ji. I'm Dr. Mu-Hua Yang from National Yang-Ming Jiao Tong University. So the first speaker is Dr. Yung-Yeh Su from the National Institute of Cancer Research of NHRI. And Dr. Su obtained his MD degree from Kaohsiung Medical University, and he also obtained his PhD degree in the National Cheng Kung University. Now he is an assistant investigator of the National Institute of Cancer Research. And Dr. Su is a physician scientist, and his major interest is the GI tract and the hepatobiliary and the pancreatic cancer. And he has initiated many investigator-initiated trials and performed many outstanding translational research. Today, Dr. Su will give us a talk about the precision medicine in GI tract of cancer. Let's welcome Dr. Su.
Thank you, Professor Yang. Hello, everyone. I'm Yung-Yeh Su from National Health Research Institute, Taiwan, and it's my great honor to be here to share some of my experience of precision medicine in GI cancer. And today I will talk about two topics. The first is pancreatic cancer, and the second is liver cancer. So why I'm focusing in pancreatic cancer is because that currently pancreatic cancer is the third leading cause in the United States, but it's predicted to be the second by next year. So as you can see here, as the lung cancer is a significant decrease in mortality, there is almost no change in pancreatic cancer. So pancreatic cancer will now be a major problem in the future. So first of my study is looking at the pharmacogenomic study in the treatment of pancreatic cancer. Liposomal irinotecan is the new formulation of the irinotecan, and it's currently the only approved drug as the second-line treatment in pancreatic cancer. So from many years ago, we already know that the metabolism of irinotecan is through the gene named UGT1A1, and the polymorphism have significant impact of this metabolism. That's a story we already know in the traditional irinotecan. But this kind of new formulation, and there is this kind of drug, irinotecan is encapsulated in the liposome, and there is the significant difference of the pH value inside and outside the liposome. So actually we don't know if this will have some impact on the drug metabolism. So I think this is a quite common story that irinotecan is metabolized by UGT1A1, and there are two common SNP. One is in the promoter area. In the general population, there are 6 repeat of a TA box, but some people will have 7. So we name this UGT1A1 star 28. And another happens in the codon 71. There is a G2A variant, and we name this is UGT1A1 star 6. And most importantly is that in the phase 3 pivotal global trial Napoli 1 study, UGT1A1 star 28 is checked, but star 6, which is more common in Asian, is not checked. So actually before our study, there is actually no data on star 6. So we conduct the study using some early phase trial data of the liposomal irinotecan, as well as patient from National Cheng Kung University Hospital, so a total of 162 patients. And we are confirmed that STAR6 is more common in Asian than STAR28. And we also noticed that 9% of patients will have either homozygosity or double heterozygosity. And we can see here is that for patients with homozygosity or double heterozygosity, the incidence of grade 3/4 neutropenia is significantly higher, around 75%, compared to wild type or single heterozygosity, around 40%. So this data actually suggests that these patients should have initial dose reduction. Otherwise, they will have very high risk of neutropenia. And the other common side effect of liposomal irinotecan is diarrhea. But we did not see a significant difference of this genotype. But some part may be due to the diarrhea is not so common in Asian population of this drug. So maybe that's why we cannot demonstrate there is a significant impact of this SNP. But anyway, from the left side panel, this is an important data show that currently the package insert of this drug, liposomal irinotecan, only recommend the initial dose reduction in UGT1A1 STAR28. But our data show that this Asian common SNP, UGT1A1 STAR6, have also same impact in the grade 3/4 neutropenia. And therefore, we should also check STAR6 and adjust the dose accordingly. And the second part of my study is we are trying to investigate the DNA repair pathway in pancreatic cancer. Because start from the PARP inhibitor story, start from germline BRCA mutation, and in other cancer type, they are actually extended to not only germline but also somatic, and in ovarian cancer is even approved in using the HRD panel. But currently, pancreatic cancer, the indication is still limited to BRCA mutation. So when we extend it to the homologous recombination pathway, there are actually a bunch of cancer genes, a bunch of the DNA repair genes. Of course, this is so-called core HR genes, but we can see there are actually a lot of other genes. So this is not novel, but there is actually no data in Taiwan, so we're trying to establish our own data. So we collected around 500 patients in National Cheng Kung University Hospital and Kaohsiung Medical University Hospital. And we reference this paper that around 80 cancer susceptible genes, which may be related familial cancer history. And we do the exome sequencing and analyze these 80 cancer susceptible genes. And furthermore, we want to investigate the impact of HR genes. So we also reference this article that highlights this kind of HR genes. So we in those 80 cancer susceptible genes, actually almost half of them were involved in DNA repair, and we can show that our germline mutational landscape is quite similar to the report from Western country that BRCA2 is quite common, and the ATR or ATM is also common in our patient. So in the second part of the study, we trying to investigate whether this kind of mutation will have impact on the patient outcome. So we trying to investigate if there will the germline mutation profiling will have impact on the chemotherapy response. This is, again, this is not novel, but there is no data in our patient. So we're trying to see if our patient have a similar phenomena. And so we excluded that patient receive non-standard treatment or early stage patients. And finally, 320 patients with advanced stage pancreatic cancer receive first-line standard chemotherapy in these two hospitals is included in the efficacy analysis. And among these patients, 32 patients had pathogenic or likely pathogenic mutation in HR genes. And for the entire cohort, we can see that patients with germline HR mutation actually have similar overall survival with other germline mutation or no germline mutation, which means that germline HR mutation is not a prognostic marker. But when we see in the advanced stage patient receive first-line chemotherapy, that is consistent with the literature that for patients with HR mutation and receive first-line chemotherapy, they will have very good response. By contrast, for those receive, which is significantly better than those treated with non-platinum based chemotherapy. And for the blue line, for patients without HR mutation, the outcome is basically the same, no matter you treat it with first-line platinum or non-platinum based chemotherapy. So based on this study, we can show that in our patient, the germline HR mutation can be a predictive biomarker and can help physicians to choose the first-line chemotherapy. And the second part of my talk, we were trying to study in the liver cancer, and also the liver cancer is also increasing disease burden. Currently, is the number 5 leading cause in the United States. And it's still the green line here is continuous increasing. So it's expected it will be the fourth leading cause of cancer deaths by 2030. So this is the data from Japan, but I think we have similar condition that although viral hepatitis had been eradicated, but the alcohol-related liver disease and the metabolic-related disease is significantly increased recently and will become the major cause of liver cirrhosis and probably liver cancer in the future. And so in our study, we focus in the locally advanced disease because we trying to do through a window of opportunity, this kind of study approach, try to do some translational research. And the concept of our IIT is that because this is the concept from other cancer type, beginning with melanoma, that neoadjuvant immunotherapy can induce more diverse immune response than adjuvant, because when you give before surgery, there are much cancer cell and much diverse cancer cell. So theoretically, you can induce more diverse and more abundant immune response than after resection. So actually, there is a trend toward neoadjuvant or neoadjuvant plus adjuvant, so-called perioperative immunotherapy across cancer types. So this is the IIT conducted by Professor Xu Jun, and we we apply this nivolumab 3 milligram per kilogram plus ipilimumab 1 milligram per kilogram every 3 weeks to so-called potentially resectable HCC. And the patient generally will receive 2 cycles of treatment and have evaluated the tumor. And if it's resectable, we'll proceed to surgery. Otherwise, we can apply 2 more cycles. And if the patient remains unresectable after 4 cycles, then we will switch to the standard of care. So finally, we enroll 43 patients in the study, and 24 of them finally can receive surgery. And because this is the borderline resectable disease, so actually most of the patients actually have very advanced disease. You can see here that more than 60% will be the BCLC stage C, that's advanced disease, and the median tumor size is 8.7 centimeters. And consistent with prior study of this kind of combination, and but because this is a neoadjuvant study, and we only give 2 cycles or 4 cycles. So actually, some patients probably did not have enough time to achieve partial response, but we can still see that around 20 to 30% of patients will have some different degrees of tumor reduction, and most of them are able to undergo surgery. And for those patients undergoing surgery, we can see consistently with prior literature that 1/3 of patients will actually have very significant immune response and achieve major pathological response, defined as more than 90% necrosis in the tumor. And this kinds of phenomena is consistent with other groups. So we are invited to join this kind of international collaboration. And finally, our study can show that a major pathological response is a surrogate endpoint and probably could be considered as an endpoint in future neoadjuvant studies. And also in this same study, we identify that some tumor will have significant fibrosis, and but their image is almost the same in the image study. So we call this ghost tumor. And collaborating with our colleagues across many hospitals in Taiwan and Japan, the study show that this kind of ghost tumor actually have almost same good excellent response survival with those have complete response. So back to our translational research, we are wondering if there is any biomarker that can predict or correlate with immune response. And we are able to show that dendritic cells actually have very good correlation with tumor response. And also the TLS signature is also correlated with tumor response in our patient sample in both pre-treatment biopsy and the post-treatment pair sample. So using the multiplex IHC staining, we can also quantify the TLS number in our patient sample, and we observe the similar condition with the RNA sequencing data that TLS number is correlated with tumor response. And our colleagues from National Taiwan University also performed some preclinical study trying to figure out what's the role of TLS in this kind of immune activation. So we performed the preclinical study in mouse and treated with, just like our patient, treated with dual immunocheckpoint inhibitor, and one group of mouse will have B cell depletion by anti-CD20. And we can see that consistent with our patient data, that dual checkpoint inhibitor will have significant tumor response. And interestingly, after depletion of B cell, this kind of immune response disappear. And this is also reflected in the mouse survival, that the survival is almost the same with isotype. So again, in the RNA sequencing data, in the left panel is we just show that it is our patient data, but interestingly, and in our mouse data, you can see that mouse treated with dual check inhibitor will have significant increase in the DC signature. And this effect is disappear after B cell depletion. And also same in the TLS signature. This in the left side panel is our patient's data, and in the right side you can see the mouse treated with dual check inhibitor. They will significantly increase in the TLS signature and correlate with tumor response and survival. And the effect is gone after B cell depletion. And also similar to our patient, that after treatment with dual check inhibitor, there is a significant increase number of TLS in the tumor microenvironment, and it's gone after B cell depletion. So consistent with the result that we can show 9% of our patient in pancreatic cancer will have UGT1A1*6 or STAR-D28 homozygosity or double heterozygosity, and the lower starting dose of liposomal irinotecan is recommended. And around 10% of patients have germline HR mutations, and this will help our patient to select first-line treatment. And finally, in the liver cancer research, we show that the dendritic cell and B cell within the tertiary lymphoid structure are very important in the checkpoint inhibitor therapy. Thank you for your attention.
Thank you for Dr. Su's very interesting talk. Is there any question from the audience? So if there's no question, I have one question. So the increasing evidence about the B cell in predicting the immune checkpoint inhibitor response. So you have mentioned about your finding about the ghost tumor of liver cancer after immunotherapy. So I'm wondering whether the ghost tumor also harbor TLS, or the TLS cannot be found in ghost tumor.
Yeah, so I think we need to define, which kind of area you think is within the tumor, because a so-called ghost tumor is that there is the 90% of necrosis. So which means the majority of the tumor area is actually no cell within that. There is only necrosis. So actually there is nothing within that environment. So but we did not check the surrounding area. So maybe it's a really good point. We should check that.
Because of the limitation of time, let's thank Dr. Su again for his great talk.
Thank you.